Professor Ayman, can you to start sharing?
Okay, Professor Amr, you have to stop sharing.
Professor Amr.
Yeah,
I think we are, the webinar is live now. Everybody can see us and hear us. I think so, Dr. May.
Yes, so doctor, I opened the waiting as you asked for, and now the number is increasing slowly. As you can see it, we are moving upwards with the number of attendees, 119, 120, and we're coming up.
طيب Dr. Amr, why do stop sharing your screen?
I'm trying to get out of it. Okay.
From the top. Okay, this is Dr. Ayman now. Thank you very much, Dr. Ayman. Dr. Ayman is a seasoned speaker. He very familiar with Zoom and other platforms.
Right?
Yes. Okay, sir.
Okay.
Yes, sir.
Just a second. Okay.
Okay. So, Dr. Ali, would you like to give it another try, or are you happy? Now I want to say hello to Professor Mohammed Mumtaz.
Hello, Dr. Hassan. How are you?
Chair of the Egyptian Society of Obstetrics and Gynecology, our my co-moderator, and we thank you very much. Dr. Ali, would you like to share your slides? Just a final try. Dr. Ali, we can't because you muted, no? Okay, sir.
You have to open your microphone.
Yeah.
Yes, I was muted. I was saying that I'm fine. I'm okay.
Okay, fine. And if you will allow me now we have 3 minutes to go. So if you will allow me, I will start sharing my screen to make sure that it
Professor
is,
Hassan.
Yes, sir.
Professor Salam. Yeah,
Yes,
we have to put the rules. Now, are the questions to be submitted through the chat or through the Q&A?
No, the Q&A, and I will say this. I will be saying this. Can you see my slides now?
Yes.
Yeah, okay. Well, I prefer leave till we start then. Yes, we will, all the questions are going to go to the Q&A section, not the chat section. Now, I'm going to do a presentation. I'm Professor Mumtaz going to also to say a few words about the Egyptian Society of Obstetrics and Gynecology. Each one of us 3-4 minutes, and then it will be Professor Bitzer, then Professor Ali, then Professor Amr Nouri, and then Professor Ayman. So after I do the presentation, I will leave everything to Professor Mumtaz. Professor Mumtaz will carry on presenting a speaker after the other. By that time, I will be looking at questions and preparing them for the last. We may have 1 or 2 questions at the end of each speaker, just to liven things up. If we either will come up with a question, or Professor Mumtaz will come up with a question, or we'll find a question from the audience. So this is what we have in mind, really, and thank you very much for everything. So if everything is, everybody is happy, I can start now because it is 2 o'clock sharp. Shall I start?
Please do. Yes, okay. I think so.
Just one question. I think is Ali the first speaker, or? Yeah.
No, I think you're the first speaker, Johannes.
Okay.
Yes, Professor.
Okay.
Dr. May, are we online?
Yes, we are.
Can I start then?
Yes, please do.
Okay. Okay, good afternoon, ladies and gentlemen. I am Hassan Salam. I am the chair of the Executive Committee of the Royal College of Obstetricians and Gynecologists, Egypt. I want to welcome you all to this webinar entitled Female Contraception and Update. The webinar is organized jointly between the Egyptian Representative Committee of the Royal College and the Egyptian Society for Obstetrics and Gynecology, which is presented today by Professor Mohammed Mumtaz, who you probably all know. Now, I want to start by thanking all our distinguished speakers. Forgive.
I think Professor Salam is disconnected. Dr. May?
Probably has some local issues.
Yes, he will be reconnected shortly.
Okay.
I cannot hear.
Mumtaz, I sent you a message on the WhatsApp. Please start with the message till the Professor Salam joins.
Okay.
Look at the WhatsApp message, please.
Okay. I didn't get it, Yam. Shall I give my presentation now?
That's fine. Okay.
It's up to you.
Just a second, I'll send it to you again. Okay, now it should, you received it now, Mumtaz.
Okay. All right. Do you see me? Because I can see only the shared screen from...
Yes, we can see you, Mumtaz, Professor Mumtaz.
Okay. Thank you very much. I'd like to welcome you all on behalf of Professor Hassan Salam and myself. We'd like to welcome you all to the webinar on female contraception and update. It is, as Professor Salam said, jointly organized by the representative committee, the Egyptian representative committee of the Royal College and the Egyptian Society for Gynecology and Obstetrics. The meeting today will be started by supposedly Professor Salam talk, and then my talk, and then Professor Johannes Bitzer will give us a talk about new technologies in fertility control, principles and availability. Professor Bitzer is Professor Emeritus of Obstetrics and Gynecology at the University Hospital of Basel, Switzerland. He is the ex-president of the European Society of Contraception. He is a member of the Executive Committee of the European Board and College of Obstetrics and Gynecology. The next speaker will be Dr. Ali Kobba. He will give us a talk about medicated intrauterine systems, 3 years on beyond contraception. He is the lead consultant in colposcopy and reproductive health care at Guy's and St. Thomas Hospital, London, UK, board member of the European Society of Gynecology and vice president of the European Society of Contraception and Reproductive Health. The next speaker will be my dear colleague and friend, Professor Amr Nouri. He will give us a talk about contraception in the COVID-19 era. He is the professor of obstetrics and gynecology at Cairo University, and he is the former chair of the Egyptian Representative Committee of the Royal College. The last speaker will be Professor Ayman Abu Noor. He will give us a talk about fourth generation contraceptive pills. Could we dream of any better? Of course, Professor Abu Noor is Professor of Obstetrics and Gynecology and former head of Department of Obstetrics and Gynecology at Ain Shams University in Cairo, Egypt. At the end, we will have Q&A, question and answers. I'd like all participants, please, to put their questions in the Q&A, not in the chat button. So if you want to do a question, you just press on Q&A and then put your question there. Dr. Hassan Salam will revise them, and at the end, we will give a summary of these questions. I'm gonna give you a very short talk about the Egyptian Society for Gynecology and Obstetrics, and I think Professor Salam will give us a talk about the Royal College. If he's not online, I would suggest that Professor Nouri can give us this brief.
I am online.
Okay, Tfadal, Dr. Hassan. You will start by giving the presentation on the Royal College, the Egyptian Representative Committee, and then I will follow by the Egyptian Society of Gynecology and Obstetrics.
Okay, can you see me like this?
Yes, Dr. Hassan.
Yeah. Okay, I was saying that the Egyptian Representative Committee consists of 4 fellows and 4 members. You can see the names, and we have also a liaison committee, which is based in the UK, chaired by Professor Muhammad Al-Fattah, Professor of Urology in Aberdeen. Now, I would like to welcome our first distinguished speaker, Professor Johannes Bitzer. He is Professor Emeritus of Obstetrics and Gynecology at the University of Basel in Switzerland, and is an ex-president of the European Society of Contraception, a member of the Executive Committee of the European Board of and College of Obstetrics and Gynecology, and he's going to talk to us about the new technology in fertility control, principles, and availabilities. Then I would like also to welcome Dr. Ali Kubba. Professor Kubba is a lead consultant in colposcopy and reproductive health at Guy's and St. Thomas's Hospitals in London. He is a board member of the European Society of Gynecology and vice president of the European Society of Contraception and Reproductive Health. We want to thank him very much for being with us. He's going to talk to us about the medicated intrauterine systems 30 years on and beyond contraception. I would also like to welcome Professor Amr Nouri, who is Professor of Obstetrics and Gynecology at Cairo University and a former chair of the Egyptian Representative Committee, my predecessor of the Royal College. He's an executive board member and the honorary treasurer of the Egyptian Society for Gynecology and Obstetrics, and he's going to talk to us about contraception in the COVID-19 era. And then, lastly but not leastly, Professor Ayman Abu Noor, who is the professor and former chair of the Department of Obstetrics and Gynecology at Ain Shams University in Cairo, and he is going to talk to us about the 4th generation contraceptive pills and what could we dream of any better. And as I said, I would like to welcome my co-moderator today, Professor Mohammed Mumtaz, who is professor and former chair of Obstetrics and Gynecology in Cairo University, and he's currently the vice president of the Egyptian Society for Gynecology and Obstetrics. I want to remind people, as Professor Mumtaz said, that we would like to receive your questions and answers on the Q&A section, not on the chat section. And I would take this opportunity to thank Techno for their support. And now I will leave the microphone and the screen to Professor Mohammed Mumtaz, who is going to tell us something about the Egyptian Society of Gynecology and Obstetrics. Professor Mumtaz.
Thank you, Dr. Hassan. I'd also like to thank very much the Techno company for giving us the opportunity to be online with this distinguished speakers group, and of course to be with such a large number of audience. I think there are more than 800 registered now. The Egyptian Society of Gynecology and Obstetrics is the formal society for gynecology and obstetrics in Egypt. It was established in 1953. It was formed as a part of the Egyptian Medical Society, which is originally established by Ali Basha Ibrahim in 1930. Ali Basha Ibrahim was the first Egyptian dean of Qasr al-Aini Faculty of Medicine. he became the Minister of Health in 1940, and later on, after being the Minister of Health, he returned to Cairo University as the director of the, at that time, Fuad, the first university, which became later Cairo University. Egyptian Society of Gynecology and Obstetrics is the formal Egyptian representative in the FIGO, the International Federation of Gynecology and Obstetrics. And of course, it is the largest society in the world that contains all the national societies, including Egypt. The founding meeting was in 26th of July, 1954, and Egypt was one of the founding members of the FIGO at that time, because at that time we had already established the local Egyptian Society for Gynecology and Obstetrics. It contains more than 130 professional societies, and it is the formal office for the whole world for gynecology and obstetrics. We have a lot of benefits, of course. I will not go through them, but one of them, of course, is to have these webinars. And I'd like to thank very much Professor Hassan Salam and Professor Amr Nouri for organizing such a meeting in collaboration with the representative committee of the Royal College for Obstetrics and Gynecology, because it is one of our main aims. Of course, the Egyptian Society will try to collaborate with other societies as we do now, and we hope that all Egyptian doctors will be members in the near future. We would like to thank you for your collaboration and thank very much Techno for their support. Do you like to introduce the first speaker, Dr. Hassan?
Yes, please.
Okay. I would like to ask Professor Blitzer, our first speaker, to give us his talk. Please, Professor Blitzer, please share your screen.
You stop sharing first, Mohammed.
I will.
Well, Professor Hassan, Professor Mortaz, can you hear me?
Yes.
Yes.
Okay, first of all, thank you very, very much for the invitation to participate in this meeting. It was always a pleasure to come to Egypt, and it is now another way to get in touch with all the colleagues, and I'm really excited and happy to be with you via this Zoom meeting. I would like to talk to you about something which is a little bit beyond our usual subjects in contraception, and it is about what you could call new technologies in fertility control. And I would like to give you a little bit an insight about this field. I'm trying to, sorry, many of the women in my country, but probably also in your country, are continuously confronted in the internet with what you could call artificial intelligence methods. And the question is actually, are all these things that are in the internet, is it actually old wine in new bottles? Is it something we know since a long time and now it has been sort of modernized and put up in a mass production? Because actually all these different methods, as you can see here, are available, and they are used by many women outside our consultation. It is of course something that is not prescribed in the consultation, but I think we should know about it because it may be more and more important to counsel women about this issue. Now, I'm afraid something is going a little bit wrong with my slides. Is that? I'm sorry. Can you? It's over. There are different things which are. Well,
Dr. Mai.
I try to.
No, it's not related to us. This is regarding the presentation. I think you've made a PDF presentation instead of a slide. That's why it happened. not related to the income.
Can you go back one slide and come back again, Professor Bitzer?
Yeah, I'll try. No.
Johannes, maybe if you don't use a slideshow, but go to just showing your slides as if you're editing them, that might solve the problem.
Yes, you're right, Professor Al.
What do I have to do?
Your own slideshow. Can you go? So it's okay now.
Maybe I think I'm back here. So that looks better. Well, actually, maybe I can continue with this one. The issue is, what is the old wine? I think the old wine is, of course, the long-standing tradition trying to understand what happens during the menstrual cycle, especially regarding ovulation, and by knowing about ovulation, defining the fertile window. As you know, the basic knowledge is that the egg cell is fertilizable for 24 hours, and sperm can fertilize an egg cell during 5 to 6 days. So the whole issue was, can we detect the fertile window, and by detecting the fertile window, help women to define fertile days from non-fertile days? And to do this by observing the cycle, by observing different biomarkers, I could call them. Now, the first biomarker, of course, which was used in this issue was the cycle length. This is based on the observation that the postovulatory phase is rather constant, 12 to 14 days, thus allowing the calculation of the day of ovulation. In many studies have been shown that ovulation occurred approximately 14 days before the onset of the next menstrual cycle. So it was sort of a retrospective determination. But limitations, of course, of that method were and are still the length of the postovulatory phase is not stable, but may vary between 7 to 14 days, as you can see also from this distribution. Now, the second biomarker, which was used, which is still used, is the changes in the basal body temperature across the cycle. You all know it's the progesterone surge after ovulation, which induces this temperature rise. And this basal body temperature remains elevated due to the increased progesterone levels after ovulation until next menstruation. Again, the temperature rise identifies the end rather than the onset of the fertile period. So again, it is a sort of a retrospective method. Again, we have limitations. We have the temperature measurements may be disturbed by a variety of factors. Some women ovulate without a clear rise in DPT, and the shift may vary up to 1 day before and 3 days after actual ovulation. So again, you have a sort of a window of uncertainty, of variation, biological variation. Next biomarker is the changes in cervical mucus. You know, the estrogenic mucus is stimulated by the rise in estrogen produced by the dominant follicle. The estrogen mucus is clear, wet, stretchy, and slippery, of course, facilitating the transport and the survival of the spermatozoa in the cervix. And as you know, it also leads to maturation of the sperm, capacitation. The progesterone mucus is quite different. It inhibits sperm capacitation and motility and blocks the passage of sperm. So G mucus is generally dry, sticky, cloudy, and not stretching. So the limitation, so this is also a biomarker, you could say. The limitation is that the subjective interpretation really depends on the training of the It is it's not an objective measurement, and the appearance of the mucus may be modified by other factors, except estrogen and progesterone, which may reduce the accuracy of the method. And finally, you could call it the biomarker 4 is the LHE increase, which you all know, that, you know, by determining you have an indirect indicator for the ovulation. Ovulation occurs 12 to 14 hours after the LH in the which you all know from gynecologic endocrinology. So we have, you know, sort of 4 biomarkers which would allow us indirectly to determine what happens during the menstrual cycle, and thus helping us to understand what are fertile days, what are infertile days. So if I summary, you know, we have the temperature, the menstrual cycle length, we have the LH peak, the estrogen increase, and we have the mucus observation. And in some of the methods, we have a combination of these different biomarkers with the aim to be more precise about the prediction. Because as I mentioned before, with the limitations of the observation, you have a variability which you have to integrate in your estimation and your prediction of the fertile days and the infertile days. Now, there are 2 ways how these fertility trackers can be of interest to women. One is, of course, the pro-fertility issue, increase the probability of conception in women who wish to get pregnant by having intercourse during the most frequent phase of the fertile window. In my practice, I must tell you that it helps people. Sorry, it helps that people are educated about this, because quite a number of couples think that they should have intercourse at ovulation, which is frequently too late. For the moment, there are no prospective studies to prove that the practice of this fertility awareness-based method shortens the time to pregnancy. Among those couples who do not achieve a pregnancy after 6 months, following the general advice to have frequent intercourse every 2 to 3 days. But it may be, there is some indirect evidence that it may be helpful for those people who want to have a pregnancy. It helps them to better manage also their intimate and sexual life. The other issue is, of course, contraception. That's the other use of the fertility awareness method. And the basic principle is, of course, to decrease the probability of conception by either sexual abstinence or use of barrier contraceptive methods like condom during the fertile window. So the whole business is about definition: what is a fertile day, what is an infertile day, and during fertile days, abstinence or barrier methods. Now, as I mentioned before, we have these limitations. These biomarkers are more sort of giving information about the previous cycle. So they provide non-probability information about the end of the fertile window. This we know. These days are very safe. By measuring post-ovulatory symptoms, the safest days are actually after ovulation. The critical phase in these methods is, of course, the prediction of the pre-ovulatory period in every new cycle, which is based on accurate information about biomarkers in the previous cycles. Now, this prediction, of course, depends on the regularity, the correct data input, and the probability statistics, the algorithm, based on the past input of biomarker information. The contraceptive effectiveness finally depends also on the sexual behavior of the couples. Are they really abstinent or use they barrier methods during the fertile days? This shows you that it is a methodology which is not really comparable, for example, to the pill, where you can easily make Pearl index studies. So the big issue is actually how can we help with the new technologies to increase the accuracy of the prediction of infertile days, depending on regularity, correct data input, and probability statistics. And this is what these new trackers actually try to do. They facilitate the regularity of the data input because you have your little computer with you, and they improve prediction by using the previous biomarker information by specific algorithms based on probability statistics. So I'm coming to the fact, what about now clinical use? I think the issue of fertility trackers is, of course, when it comes to contraception, they don't have any health risks. They are very tolerable, they don't have side effects, and they may have the benefit of a psychological benefit because you have the self-control. But what about efficacy? This is, of course, the big issue, because what type of studies can you do to tell something about efficacy? So you can do observational studies, retrospective cohort study of users' data input to see how many fertile days, infertile days, and how the sexual behavior was. You can do prospective cohort study of users' data input, again, to get the number of fertile and infertile days. But then you would also need, of course, clinical trials, which would need a prospective design with daily recording of data, including sexual behavior, cycle-related symptoms, with a large number of users. Ideally, it would be really a comparative study to finally arrive at a Pearl Index study. We do not have this until now. I can show you here an overview about the pregnancy rates and probabilities among the fertility track users of these different users based on studies which are moderate or have higher quality. And as you can see, some of these studies, they compare typical use with perfect use. And when you look at some of these pregnancy rates per 100 women, you get into a region which may come closer to the typical use of a pill in some of these studies, and especially in perfect use, you get failure rates that are impressive, but most of these studies still lack this clear prospective methodology. In this publication in the British Medical Journal by Uritia and Polis, a very good colleague from the Guttmacher Institute, you can see a sort of a summary. And I think that's very useful also for counseling, where you can see the type of method, which is, for example, the standard-based methods, and where you can have the failure rate in the studies published, typical use and perfect use. And you can see that there may be a large variety between typical and perfect use. And if you compare it, of course, to classical Pearl Index studies, in some of these studies, you come rather close to the combined pill of typical use. In other studies, you're quite far away. And I think the usual, the common agreement now is that probably the highest level you can reach of failure rate by perfect use would be something between 5 to 6% failure rate. So what do we finally can counsel women about? Of course, there are advantages, as I mentioned before. No side effects. They appeal to people who prefer not to use hormones. People understand better their physiology, their body, and they can also sort of change from pro-fertility to contraception. And of course, it's compatible with the teaching of some major world religion. The disadvantages is that it is finally up to the protective behavior, that you have inherent effectiveness is lower than the highly effective method. It depends much on very good user discipline, no protection against HIV, a lack of high quality effectiveness studies. Now, finally, what should we be careful about? I think it's not a method for women with strong medical reasons to avoid pregnancy. With women with long or irregular cycles should not generally rely on these methods. Effectiveness data are limited for users in other special reproductive categories like postpartum, lactation, etc. So another medical caveat is people are unable to negotiate the timing of intercourse with their sexual partner should not use this method. Other people who may experience additional challenges in using fertility awareness-based methods include recent users of hormonal contraceptives. There seems to be a change in the cycle physiology. Those with current or frequent reproductive tract infections, where you have changes in temperature. Those who have undergone female genital cutting, people on medication that may affect cervical mucus tracking, people who have physical or learning limitations, and those who have an irregular sleep, work, or travel schedule. So it looks like a large list. Nonetheless, I think more and more we may come to the conclusion, because many women are so afraid of hormones, which of course we have to correct these myths. But on the other hand, if finally the woman is unwilling to use a more effective method and strongly decides such a method, we should be able to inform women about it and evidence-based information, and also teach them how to use the method in the most effective manner. It should probably be in the future included as an option in patient-centered counseling, and we should be able really to communicate advantages and disadvantages in a way to make women understand what the pros and cons are. Thank you very much for your attention, and I'm willing to answer any questions. Thank you.
Thank you very much, Professor Blitzer. I think there is one question that is very important about the counseling for the patients for these methods. Does the doctor need to have his own view based on his opinion in the level of education of the patient, the way the patient understands or did not understand the explanation for this method? Because I think it's very, very important to have an opinion in that. Yeah. On the other hand, it's the patient decision. So how can you solve this problem? Because in this type of contraceptive method, the role of the doctor mainly is to explain. And at the end, the patient chooses. But do you think that the doctor or the counselor or the gynecologist in this condition would say that, I don't think this is good for you at the end, or he should not do that?
Well, I think this is a very, very good question, and it touches almost the ethical issues of shared decision-making. In my practice, what I'm trying to do is that I explain the advantages and disadvantages of the method, as we have seen on the last slide. And then I also try to personalize this information. For example, I think it is fair to say, look, I know you from your professional background or from the stress you have, and the question is looking into your personal characteristics. I have some questions whether this is really the best method for you. It's really, of course, finally up to you to decide it, but it is also my physician's or expert's responsibility not to harm you, and a wrong decision can harm you. So I really would like to point to these issues that for me, there are some points where I think this is not the best choice for you, although of course I accept it finally. But I think it is part of shared decision making and ethical approach that we also have a position when it comes to possible harm to patients.
We have a question, Professor
Salam, please.
We have a question for Professor Bitzer. Can I ask him?
Please,
okay.
go on.
Yeah, Professor Bitzer, how do these methods compare to the other methods based on estrone 3-glucuronide in urine and also in saliva? There are, work, an old work from King's College Hospital, Professor William Collins, working on estrone 3-glucuronide in urine and also in estradiol in saliva. And this makes the basis of these kits present in on the market. How do they compare? And again, are they recommended? Are they dependable?
Yeah, well, these methods you were mentioning about determination of LH and estrogen rise either in saliva and are more accurate and probably more efficacious finally in the practice, but they demand, of course, much more, how can I say, collaboration with the medical profession. The fertility trackers based on temperature and cycle length, of course, can be used by women themselves, actually, when they are well instructed, and they would not need other more complicated interventions. But the more you integrate LH determination into this whole concept, the results regarding efficacy are better. There is no question. Yeah.
Thank you very much. I'll leave it to Professor Mumtaz to carry on.
Okay. Thank you very much, Professor Blitzer. If I may ask you to stop sharing your screen, please.
Stop, yeah.
Okay. Our next speaker is Professor Ali Koba. He will give us the presentation on medicated intrauterine system, 30 years on, beyond contraception. Professor Koba, please.
Thank you very much. Can you hear me?
Yes.
Excellent. Thank you very much for the organizing group for inviting me to talk at this meeting. You can see in my presentation slide, there are two images. One is of Big Ben. This is simply to tell you that I work at St. Thomas's Hospital, familiar to a lot of people here, and it's just at the end of this bridge, Westminster Bridge there. But I also put some art from Iraq, which is where I come from. This is a painting by Rifat Shakir Hassan, who's one of the eminent artists from Iraq. And it's called Bustan al-Ma'rifa. So this is the Arabic, which is essentially the garden of knowledge. This sold last year for over £250,000. And the point about it is I'm delighted to be talking to an audience which is global, but also based in Egypt, because we always in the Arab world look for Egypt as Bustan al-Ma'rifa. Let's see how I advance my slides. So these are my disclosures, and I used the opportunity to salute all the healthcare heroes for looking after us and everybody else during these challenging times. My presentation is going to essentially talk about the medicated intrauterine systems, but I'll also highlight the importance of long-acting reversible contraceptive as the contraceptives for the modern age. I'm going to, if I have time, talk about a life course approach in relation to these methods and keep the patient-centered strategy in our view. I think in any contraceptive decision, the choices have to be well balanced, i.e. you have the benefits, the contraceptive efficacy, as well as the side effects and the risk. Patients tend to go for trusted methods, and I think intrauterine contraception has been around for centuries, because the view is that the Arabs were the first people who thought about the idea of foreign bodies inside females, and they used this for the female camels to stop them getting pregnant during long journeys in the desert. As far as the intrauterine system, Mirena obviously was the first one. It was licensed, came out to the market 30 years ago in 1990. This is the time milestones. These are the time milestones. And we know that in 1960, we had the non-medicated IUDs and also the introduction of oral contraception. In the 70s, there was a lot of work on using progesterone on an IUD. The progesticert was the prototype. It was a bit of a disaster because you needed high doses of progesterone, 1. 2, it expires very quickly, so the license was only 1 year. 3, it didn't work that well, so there were failures. But more importantly, there was a high rate of ectopic pregnancy. Research on Mirena started in the 70s and was launched in 1990. And of course, over the past 30 years, we've got a lot of sort of endocrine and basic sciences studies, but we also have real-life experiences, and the story goes on. And of course, again, thinking of methods that are trusted, the experience currently is over 110 million woman years since the launch in 1990. Looking at efficacy, Johannes presented to you the idea of ideal use, or perfect use as you call it, and real life use, which is typical use. And this slide from James Trussell highlights the difference between the long-acting reversible contraceptives, where efficacy is high regardless of the user. Here, the user has to do something, has to either not have sex or put a condom on or remember to take the pill. So long-acting reversible contraceptives are really the ones that we should be promoting to our patients. And you can see with the medicated systems, a failure rate of 2 in 1,000, which is actually better than the failure rate of female sterilization. And if we compare Mirena, for instance, with the copper IUDs, you can see that there is a difference. So this is the 1-year comparative data looking at the Nova-T and another study with the T380. And you can see definitely for the Nova-T, the efficacy difference is technically 10-fold. If you look at the 5-year comparative data, it is exactly the same story, for instance, with Nova-T. So we technically say that for the IUS, the failure rate is around 2 in 1,000, and it is highly effective over the 5-year life of the IUD. Not only that, but if you compare women using a copper IUD to a woman using a medicated IUD, with a copper IUD, we expect some increase in menstrual flow. With the medicated IUDs, we expect a reduction. So definitely in the Middle East and the Arab world, where anemia is a problem, if you are going to use the intrauterine method and try to avoid the patient tipping into having anemia because of blood loss, then the medicated IUDs such as the intrauterine system would be better. More importantly, we can talk, there is always anxiety. I know that in my Middle Eastern patients, there's always anxiety about pelvic inflammatory disease with the use of IUDs. And of course, IUDs will only cause pelvic inflammatory disease if the woman is exposed to a sexually transmitted agent. But comparing a medicated IUD, the LNG-IUS, with a copper IUD, you can see there is a small difference in the PID risk. It is statistically significant. And this may be important where there is a high risk of getting sexually transmitted infections. Definitely in Western societies, young people are a much higher risk at getting STI. So it has an advantage there. This is a slide from the EURAS study for Mirena, which is the active surveillance study, which looks at real life effects. And this compares the LNG-IUS with the copper IUD. And you can see again, the difference in efficacy you're talking about the IUS being about 5 times more effective with a failure rate, as I say, of 2 in 1,000, but also ectopic pregnancy. And that is an important thing to remember, that actually the IUS probably reduces the ectopic pregnancy rate in a significant way. And indeed, you can see that the confidence interval is significant in both. I just stuck this slide from, this is a Norman Rockwell painting. And if you go to Denver, there is currently a Norman Rockwell exhibition at the Denver Museum of Contemporary Art, I think. This is just to highlight that in the UK and definitely in many of the European countries, we have abandoned the idea of needing to check an IUD at intervals. So we don't ask the woman to come back in 6 weeks' time just for us to say, you're okay, because you tell me you're okay. We tell the woman to come back if she has a problem. If a bleeding pattern changes, if she gets pain, if the thread of the IUD looks longer. And we will see her essentially to replace the IUD. This saves money for the healthcare system and actually is much more convenient for the woman herself. Want to talk about long-acting reversible contraceptives. In general, they have advantages over the short-acting methods. These don't have estrogen and therefore they are safe. You just need to fit them and forget them, as we've just seen. They are clinically much more effective. They are more cost-effective. If you think of a device that stays for 5 to 10 years, you make your money fairly quickly within a year of using it. You can use it for both young and old, and obviously it is important where there is issues around access. And we can see that, for instance, in our countries where there is an issue around fertility rates. In my own country, in Iraq, the fertility rate is much higher than you're doing in Egypt. You're doing very well. You need a method which is quite effective over a long period of time. And I put this slide because I think it's also a good method where access is an issue. And this is about contraception for women who are displaced, who are refugees. As you know, our world is pretty involved in conflicts, and I think it's something that we need to think about. Let us now talk about Mirena as a prototype of the intrauterine system, just to highlight that it has a hormone reservoir. The hormone reservoir has 52 milligrams of levonorgestrel. It's 32 millimeters wide, 32 millimeters long. Works through thickening cervical mucus, and therefore it essentially stops the sperm from getting to the egg, inhibiting sperm maturation, probably by changes, by biochemical changes inside the uterus, and suppressing endometrial maturation. But one of the points that I think is very relevant to us, to the population we deal with, is that the mode of action, therefore, is mainly through inhibition of fertilization, stopping the sperm from getting to the egg, essentially. It's not by prevention of implantation. And this is the reason why, as you've seen previously, Mirena has a much lower risk of ectopic pregnancy than a copper IUD. And this is also why Mirena cannot be used as a postcoital emergency contraceptive. If you're going to use an intrauterine method, you use a copper IUD, really because of this reason. Now, beyond contraception, the therapeutic roles of intrauterine systems. And in the UK, we use this very important guideline from the National Institute of Clinical Excellence. It's been updated since 2007. So some of the slides will take information from that. So what do we know about the IUS? We know that it works quite well for heavy menstrual bleeding, and it works quite quickly. This is the famous Anderson paper, which essentially showed a significant reduction in blood loss in menorrhagic women. Remember, we've seen a slide about women who are not, there's blood loss there, but it works much, much better in menorrhagic women and reduces the blood loss very quickly within 3 months. And this is incremental. So at 12 months, you have a 97% reduction in blood loss. And this obviously translates, again, thinking of anemia, which is endemic in our societies, it translates into increasing the concentration of hemoglobin and the ferritin reserve. And we can think about how we use these medicated devices within the context of the FIGO classification for abnormal uterine bleeding, the so-called palm coin. These devices are quite good for the coin aspect of the FIGO configuration. So it's good for women with bleeding disorders. It's very good for dysfunctional bleeding, be it dysfunctional bleeding early in a woman's life or in women over the age of 40, for unexplained endometrial dysfunction, non-classified types. But the point I wanted to make on the palm side is that though Mirena is not licensed for adenomyosis or for the management of fibroids, the menorrhagia part of this, the heavy menstrual bleeding part of this, can still be treated with Mirena if there are no other contraindications. And I'm going to show you a slide on this. The same would apply if you can fit it, if the cavity is regular. Actually, in some cases, even if the cavity is not regular, if you're not using it as a contraceptive, you might get some benefit. So it is important in a number of contexts. I'm going to show you a couple of slides. This is just for completion of the talk about the therapeutic impact, but these are areas for further research. These are not licensed indications. So a number of papers looking at adenomyosis, and they show that the medicated devices reduce the pain score, reduce the bleeding and dysmenorrhea, which is understandable, but as a matter of fact, also reduce uterine volume. So, and that will result in much more satisfaction from the patient's point of view because they become less anemic. A controversial, actually, and then we have to remember the other licensed indication of Mirena, which is for endometrial protection. So we use it for the prevention of hyperplasia. For instance, it's a good method for women with polycystic ovarian syndrome. It can be used with systemic estrogen replacement therapy in women in the menopause. And in selected cases, and you have to discuss it with the oncologist, it may be used in women using tamoxifen who may be at a risk of endometrial abnormalities. An area which is more controversial, it's the use of these devices in managing atypical hyperplasia. There is a lot of research, mainly from Southeast Asia and Japan, and I'm not going to spend too long on this, but just to say that it is an area that is of interest in the research context. The life course approach. So we're looking really at methods that work for young people. These are my 2 slides of that. For women who are spacing pregnancies, and for older women who may be wanting to use HRT because they have full of the vigor of life and they want to essentially have a high quality of life. For the nulliparous women, the NICE guideline on long-acting reversible contraceptive says it's an appropriate method. We talked about the reduction in PID, the reduction in HMB, the reduction in dysmenorrhea. So these women are less likely to have interventions which may affect their fertility. They can switch off, take it out when they want to have a baby. Return of fertility is very high. It's good for teenagers with bleeding disorders. Raizan Kadir from Iraq, who's the professor at the Royal Free Hospital in London, has a large series of women with things like von Willebrand's disease, teenagers, which have had Mirena fitted and have done extremely well, going through universities, starting their careers without worrying about their periods. And in real life, we know that the continuation rates with Mirena versus the pill are a bit higher. Obviously, the woman who has finished her fertility, wants to be sterilized, is much better served with the levonorgestrel IUS because it's reversible, it's low cost, doesn't involve an operation, it's an office procedure, so safer. It deals with heavy menstrual bleeding, and we know that it reduces the risk of hysterectomy. The postpartum period is another area where the IUS works quite well. We want a method that you can more or less, the woman has before she leaves the maternity unit, because sexual activity can be resumed fairly quickly. Lactational amenorrhea method only lasts for 6 months, so you want something which is much longer, which the woman doesn't need to think about. And here I want to promote something that our college is very, very keen on, which is the immediate post-placental placement of a device, and Mirena seems to do better than copper IUDs at cesarean section vaginal delivery. There is a small study from King's College showing that putting a Mirena before you close the uterus at cesarean section is really a very good idea. Now you say, well, what about perforation? The perforation rate is much like the general perforation rate with IUDs, especially since you're replacing the device yourself. Displacement is higher, so partial expulsion is higher, but is acceptable. And if you look at women 6 months later, more of them are protected against pregnancy in spite of possibly some expulsions than women who did not have a long-acting reversible method. And of course, the device is safe for the baby. So studies that have looked at growth, weight gain, tooth eruptions, breastfeeding, walking, and so on, show no difference between people who have a hormonal method or otherwise. Continuing with the life course, what about the perimenopausal woman? So you can see Barbie here about 20 years ago when she was 45, really thinking about contraception. You want a method which is very effective. In the woman over the age of 40, this is an extremely effective method. In the UK, the Faculty of Sexual Reproductive Health essentially says that if you fit a Mirena in a woman at the age of 45, she can keep it beyond 5 years until she goes to the menopause. If the woman gets menopausal symptoms, hot flushes, night sweats, you can start her on estrogen. The Mirena will give you the endometrial protection. And obviously it is good for a lot of the gynecological problems that are seen in women over the age of 40, and it is free from medical risk. You can see that the pill, the combined pill, satisfies this, the gynecological protection, but has an issue because it's estrogen containing about adverse effects. So good for the menopause, just add estrogen. It is also good, I'm not going to have time, for women who are wanting to use contraception but have reasons not to use estrogen. And obviously, if you look at real life experience, this is the work of the Choice Project from St. Louis, Missouri. Jeffrey Pipert, Professor Pipert, is the lead in this. If you Google him, you'll find about 40 studies in his name. And you can see the continuation rate of the LARC methods at 12 months, and the same actually at 5 years, is the most popular method to continue with is the IUS, the IUD, and subdermal implants. Just to highlight that we now have a family of intrauterine systems. So we have Mirena, which is the release 20 micrograms. We have JDES, the smaller device, releases 12. And we have Kylina, which releases 16 micrograms a day. These devices are smaller. The most important thing is that they have a smaller insertion diameter. And the new devices, Kylina and JDES, also have a silver ring at the top, which makes them easier to identify with ultrasound. And you can see that the hormone levels would be different. And I just wanted to highlight, because it may be important for your patients, that the amenorrhea rate is lower with smaller devices. So this is JDES, and you can see even at 1 year, it's about half the amenorrhea that you get with Mirena. So if you want a choice, we do have a choice. And my conclusion slide is that these are methods that allow women to go through education and career and therefore improve the status of women. They're fertility preserving and therefore good for women who are thinking about children. And they also mitigate against poverty because you use less, you need less sanitary protection during menstruation. It is good for the healthcare system because you probably will end up with much fewer interventions. But more importantly, it's also seen as a green contraceptive because, as you know, sanitary towels are not biodegradable. And if we use less of them, you know, we don't have these millions of tons of sanitary towels going into fill sites. One of the things for the future is there is now work looking at the extension of the license for Mirena. And we possibly, you know, the next time we meet and talk about this, Mirena may be licensed for longer than 5 years, 6 years, 7 years, possibly 8 years. I'm the Vice President of the European Society of Contraception. So this is my advert slide. We'd like to invite you all to the next Congress of the European Society, which is in Ghent in Belgium. So Ghent is a historic city, is a beautiful city. The chocolate is good, the beer is good if that is what you want, but Ghent is also, the Ghent University has a massive department of reproductive health. We hope to meet many of you around this time next year. It's the 1st to the 4th of September 2021. You have my email. You also have the website for the European Society of Contraception. So hopefully we will meet you there. And I thank you for your attention, and thank you again for the invitation.
Thank you very much, Professor Kobba, for this very, very elaborative presentation on the medicated IUD, especially Mirena. Actually, I have a question and a comment. What do you think about the use of Mirena or progesterone IUDs in cases of heart disease and cases of bleeding disorders or women on anticoagulants? How do you think that safety and effectiveness?
Yeah, it is safe and effective. So the faculty, the medical eligibility criteria of the WHO and of the faculty essentially say that it is fine for women who've had venous thrombosis, for women who actually are on anticoagulants, simply because they reduce the blood loss, as a matter of fact. The women on anticoagulants tend to have heavier periods. The anxiety has always been about, do we get uncontrolled bleeding from just holding the cervix with the tenaculum? That's not really a serious problem. We sometimes have silver nitrate sticks, and we can put a stick and cauterize the area where we hold it. Cardiovascular disease, again, it's a good method for women who have problems with cardiovascular disease. The only thing I would say is that if you have someone who is unstable and may need, for instance, some intervention, operations, at Guy's we have a very big renal unit, for instance. And for women with renal disease who also have hypertension, a progesterone-only method is a good method. And of course, Mirena would be a good method. But we tend to sometimes actually use the progesterone-only pill. These women are taking medication all the time, so it's easy for them to remember to take their progesterone-only, mainly because if they have some sort of a complication and their renal physician say, stop contraception, stop hormones, we can stop the pill much easier than fixing an appointment to remove her IUS. So it is a good method.
Professor Salam.
Yes, we have another question. Actually, we're being watched from different parts of the world. We have a question from Azerbaijan, Dr. Rogaya Farayova, and also from Dr. Ashraf Salima and Dr. Saad Sanhouri. They are asking about the medicated contraception in breast cancer and in a patient with a history of intrahepatic cholestasis during the previous pregnancy.
Okay, so breast cancer, the medical eligibility criteria, WHO and for the UK say that it is contraindicated. So that is the official response. I think in any situation where a woman needs contraception, has problems with menorrhagia, so you may be using it for a therapeutic reason, you need to discuss it with her oncologist. I've put the slide about tamoxifen. I have a number of friends who have breast cancer, who are on tamoxifen, who have an IUS, really to protect their endometrium, to not give them any problems. But officially, the WHO and the college, our college, essentially say it's a contraindication. So that is as far as breast cancer is concerned. I forgot what the other condition was.
Hepatic cholestasis.
Well, hepatic cholestasis, again, because this is, I mean, if you
Professor Ali, I have to interject. That was not the question. The question was use in a patient with a family history of breast cancer.
Oh, okay. Family history of breast cancer, you don't need to worry about it. You don't need to worry about it for any type of hormone, as a matter of fact. The WHO medical eligibility criteria and the faculty in the UK essentially say that women, you have to counsel them, that they do not have a problem with using hormones. Definitely, I was going to say for Mirena, if you think of it, after 6 months of the use of Mirena, the amount of hormone that is in the system that are systemically absorbed is equal to 1 progesterone-only pill per week. So the dose of the hormone is very small, and therefore with hepatic cholestasis, it probably is okay. We know, for instance, that in women who use liver enzyme-inducing drugs, You can't use the pill because it affects the liver, but you can use Mirena because the impact on the liver is small. Always discuss it with the physician who is attending the patient, a hepatologist, but the general advice is to say it is likely, especially if you're using it therapeutically, it is on the balance of risk and benefit, a good method.
I have another question, Professor Kuba. You said that you don't need to do a follow-up visit. Would that apply to the use of Mirena for therapeutic indication? I mean, if you're giving a patient for bleeding, for example, you would ask her, if you're okay, don't come back, or you will ask her to come back in 3 months to check?
No, I think the advice from the faculty is mainly for the use in conception. One of the things that we wanted to really eliminate is this thing that we've been programmed to do, which is you fit a device and you say you must come within a month or 6 weeks because I need to check it. And the answer, the question is, what do you check? You look at the thread. So you advise the woman to check the thread, or if something happens.
We sometimes do an ultrasound to check the position of the IOD in the cavity.
Yeah, you can do that. The evidence is that in most cases, if there have been no events and if you're sure of the way you fitted the device, you don't need to do that. This is the point is you want to reduce the number of consultations and therefore save money for the patient. If she lives in a village, she doesn't need to sort of buy a train ticket and come to you. And you need to also release time capacity within your service, definitely in these times.
By saying that you're sure of the position, would you advise to do ultrasound immediately after positioning the Mirena?
We only use that if we think the insertion was difficult or there was some anatomical problem. So for instance, if you're fitting it in someone with, let's say, a small bicornuate uterus, you want to make sure that the device is in the right place, so you do an ultrasound. I think if a woman comes with any problem or complication, ultrasound is mandatory. We do it as a matter of routine.
Thank you very much, Professor Kubba. We will move now to our next speaker, Professor Amr Nouri. Professor Nouri, are you with us?
Dr. Amr has some technical issues. He's trying to reconnect again. So if you would like to wait, okay. If you would like to replace the speech, your call.
What do you think, Dr. Hassan? Shall we move on to Professor Ayman Abu Noor?
Yes, we can, of course. Yeah.
Okay. Professor Ayman Abu Noor, are you with us, please? Professor Abu Noor?
He's muted. I think he can use Dr. Professor Ayman, are you with us? Or by the time they come, we have few questions. Actually, I have few more questions for Dr. Ali Kubba. What do you do to control the breakthrough bleeding with medicated intrauterine devices, Professor Ali?
Okay, I've managed to go get a water while you're talking. I think one of the points that are very clear with the progesterone-only methods is that we do not exactly know what is the mechanism for irregular bleeding. So the important thing is counseling, is to actually talk to the woman and say, this bleeding doesn't mean that your fertility is going to be affected, doesn't mean that this device is causing you cancer, that sort of thing. The methods, the ways people have used medical treatment is variable. So some people give mefenamic acid, some people give tranexamic acid, and these are very much on a trial basis. I think in some patients, actually giving natural estrogen will stabilize the endometrium and therefore would allow you. So sometimes we give a patch, for instance, to be used with the method. But counseling is the most important. Now, if a patient is really, her quality of life is being affected by the irregular bleeding, and if she is allowed to use the combined pill, we sometimes give short courses. This is very important. You're not really treating the bleeding. You're buying time until amenorrhea sets in. So we essentially say, we can give you a combined pill to use for a month, a couple of months probably, and then we will see how you stop it, and then we'll see whether the bleeding goes away. It's buying time, it's getting the patient to be psychologically ready for the.
Yeah, well, okay, thank you, Professor Ali. Another question, can Mirena be used with submucosal fibroid?
Well, it depends. So if the fibroid is not affecting the cavity, and in these cases, you probably have to do an ultrasound after the fitting. If you're using it as a contraceptive, it fits all right, then that is fine. I think if you're using it because the woman has heavy menstrual bleeding with a fibroid, I have patients where I know the Mirena is not fitting exactly at the fundal position. It may be slightly displaced by a fibroid, which is encroaching on the cavity. The woman is advised to use some other contraceptive, but it deals with her bleeding. And that is really very, very important. And when we have a 5-year license for contraception, for instance, if you're using the method as therapeutic, and a woman comes and says, I'm at 5 years, but my bleeding is nothing, you keep it, don't change it if she's not using it as a contraceptive. So there is a different protocol if you're using it as a contraceptive versus using it for heavy menstrual bleeding.
Thank you, Professor Ali. I think we have a question for Professor Bitzer here. It's about the digital fertility appliance. Can we depend on it? And what is the success rate? I don't know which digital fertility appliance, but probably Professor Bitzer would know better than me. Is Professor Bitzer with us?
Yeah, I'm here. I'm here.
Yes, sir. The digital fertility appliance, yeah.
Yeah, I think the best studies regarding efficacy are probably those by natural cycles, and some news are coming up by the company AVA. And I think what turns out is that under ideal conditions, regular measurement and protective behavior during the fertile days, it looks like the failure rate, as I mentioned it before, is between 5 and 6 per 100. So this is a failure rate which comes close somehow to typical use of the pill, or and which seems to be a bit better than the condom alone. So I think that is probably the information. We won't be able, I'm part of an expert group, and we were looking if we would integrate other signals, if we could improve the prediction, you know, heart measurement, etc. But it doesn't look like you can go beyond that number. Probably.
Yeah, thank you very much. There is a final question for your good self before I think Professor Amr Nouri is with us now. But somebody who's asking, can the sperm really live for 7 days in the cervical mucus?
Yeah, well, that's this is one of the issues I mentioned before, which is biological variability. There may be sperm living for 7 days. You know, all these markers are mean values somehow, and I don't know whether there are sperm living 7 days, but obviously there are very few. Let me put it that way. And all we know until now, it looks like it's 5 to 6 days. Yeah.
Yeah. Well, thank you very much.
If I may say this, you know, this is the individual use. I mean, women can enlarge for safety issues, for efficacy issues, the period of fertile window, and they can say, well, I feel only safe after ovulation. So you know, you can handle it a little bit, and depending on your willingness to accept a certain failure rate.
Yes, sir. So you really need to differentiate between the maximum fertile period and the probable fertile period.
Yeah.
For those who want to become pregnant and for those who do not want to become pregnant.
Right.
Thank you very much, Professor Bitzer. I think we're back to Professor Mumtaz to
Professor Amr Nouri, are you with us? He was with us for a moment now.
He's with us, but he's muted. Yeah.
Here. I'm
Okay.
here.
Okay, please.
I need to
Okay. Professor Amr Nouri is our next speaker. He's a dear colleague and friend, and he will give us a talk about the contraception in the COVID-19 era. Please, Professor Nouri, can you share your screen with us, please?
Can you see it now, or?
Yes, please.
Okay. Right, thank you. Good afternoon, ladies and gentlemen. It's really, I'm really excited to join you in this
we can
webinar.
see your screen, but we cannot see your slides.
You have to open your
presentation.
Your presentation on full screen.
Can you see it now?
We can see your screen.
You have to open here.
Let me check again, please.
You have to open the presentation before sharing your screen.
Okay, so let me
stop sharing,
stop sharing
and come back. Yes.
Okay, so now
open presentation.
Can you see it now?
No.
Share the screen again.
No.
Yes, I don't. No. You have started sharing your screen. Yes.
Now it's okay.
Yes, now it's okay, but
go to full picture.
Yes.
Can you see it now?
Yes, but
go to full picture, please.
Full screen, yeah.
Oh.
Can you see it now?
Yes, now it's great.
Perfect.
Okay. Perfect. Okay. Good afternoon, ladies and gentlemen. I'm really excited to join you in this webinar. Especially, we have really a good number, exceeding 500 plus of attendance in addition to the distinguished panelists with us. We all know that the global outbreak of COVID-19 cases and its pandemic raised many challenges and questions for us as a clinician about the safety, how to provide safe, quality, and equitable contraceptive care, and this will give us an impact on the decision whether to postpone pregnancy, how to initiate, to continue, or stop the contraceptives, and how to deliver the contraceptive care during the next phase of the COVID-19. We know that the novel coronavirus that emerged in Wuhan in China at the end of 2019, really it is causing severe respiratory distress syndrome, and today it's causing more than 790,000 deaths all over the world with the severe acute respiratory distress. And this disease has affected every medical service provision, including the reproductive health and family planning. And I'm not going to talk about the route of transmission. We all know about the aerosol and the secretions and the contact, but I just really want to raise one of the papers that they discovered the coronavirus in the semen and whether this would affect the contraception or not, or sexually transmitted. But there is no evidence of transmission via the genital fluid. As we can see it, for example, in other secretions, but does not mean that it will be transmitted through this. And also, all of us know the symptoms of coronavirus. The most important three now are the fever, the persistent cough, dry, and the loss of taste and smell. And we have other symptoms from headache to diarrhea to others with an incubation period of 2 to 14 days and a mean of 5 to 6 days. And also, I would like to share with you this slide that not everyone will be symptomatic. 30% will not be, will not have symptoms, and 55 mild flu symptoms and then become immune. And then remaining 15%, 5 of them really will be the problem that will need the ICU. And this group, some of them really will die, unfortunately. And we know it kills more the immune compromised people, those who really with the cardiac, with the heart, with the asthma and diabetes mellitus and other immune compromised. But this is really the cumulative number leading 22,000 million and the cumulative death of 790,000. Not only this, there are countries now showing second wave of coronavirus rise. after actually it went down. So really we are in a phase of a crisis phase. Things will go down and maybe go up like in some of the countries, as we can see here in Israel, Peru, and Australia and Japan. And very important is the COVID-19 reproductive number, which is the number infected for everyone who gets ill. So one can actually get another one, and this will give another 2. So this is the number is important. And I'm giving you an example. For example, we need the number to be only 1. This is the ideal, or less than 1. But if it is more than 1, then this is a problem, and probably there will be more restriction and more lockdown the more we get higher than 1 or 2 or 3. Well, the impact of COVID-19 on family planning, as I mentioned, it affected every health service and not only the contraceptive. As we know, there is restriction on the public movement and lockdown. People are afraid to leave their house. The increasing pressure on the National Health Service facilities. So there is prioritization to isolation and ICU, and many hospitals closed at one time the routine gynae service, which they considered non-essential visits. But again, with the new wave of rise of, or the second wave of COVID-19, there might be another close down or lock. So there is inaccessible family planning, and we are in a crisis mode, very easy to shut down, especially what is really perceived as non-essential visits. The FIGO, the federation that the Society of Egyptian Gynecology are part of it, saying that the contraceptive and family planning services are core important of essential health service and not non-essential, essential health service. And this service, access to it is really fundamental human right. So there should be a basic contraception, counseling, delivery of the products and the services, and functioning of the supply chain. And anyone really wants to get away from, to prevent pregnancy or use contraception, either because they are scared of the pregnancy itself, or they finish their family. And we need to discuss with them, the effect of pregnancy. We know that the clinical outcome of pregnant women with COVID-19 is relatively optimistic, and pregnant women are not necessarily more susceptible to SARS-CoV-2 than the general population, except in those with comorbidity, the diabetes, the asthmatic, the obese patient, the cardiac patients, and also the Black Asian minority ethnicity. So these are those are at high risk of the pregnancy. And for the effect on the fetus, now we know that there is a low rate of vertical transmission and possible transplacental transmission. However, there is no increased risk of miscarriage. So it's not teratogenic, but there is a possible fetal growth restriction. And we know that there are reports of preterm birth. Usually they are iatrogenic to save the mother from the COVID effect. So we need to discuss this with the patient to know the effect so they can take a decision for that. But there's also impact of COVID on the global axis, the lockdown measures, the isolation measures, actually stopped the production of many of the contraceptive services. For example, in India, they stopped actually exporting the progesterone at one point. Some others really, they turned it, instead of using the condom, they went actually personal protection equipment. So they either stopped the production on level of production or reduce the capacity. And even there is a delay in the delivery of the contraceptive supplies. And we know in any country, or most of the countries, to register a new contraception, it may take 1 or 2 years. But the good things of the COVID-19, that now, as exactly in this webinar, we can get access to the colleagues and health providers so that we can discuss how really to improve the provision of care to these women. So the impact of suspension of the family planning, there will be unwanted. The UNFPA, actually, they said that there might be 7 to 15 million more unwanted pregnancy in middle and low income countries if the lockdown extends from 6 to 12 months, which really this will lead to unsafe, or you will get morbidity from inappropriate use without the use of medical eligibility criteria, or there is increased burden of mortality and morbidity of pregnancy or unwanted pregnancy, and increase in the sexual transmitted diseases. And it's very important really in this COVID era is to look how to initiate, how to continue and switch or stop the contraceptive methods. The methods of initiation, it's very important that we have a golden opportunity to discuss contraception during the 3rd trimester of antenatal visits. And maybe it's a time to look about the LARC, long-acting reversible contraceptives, such as the ICD or the hormonal contraceptives, Implanon or implant or the progestogen, or maybe even the combined hormones. And it comes really as a result of this, what we are doing today is some form of telehealth, but there is also a telemedicine where you can actually go directly and communicate with the patient and give consultation through the telemedicine, and there is interaction from with the health provider. Unfortunately, there is loss of the personal touch in this part, or the face-to-face, but we get it through the internet, and we can use this for the non-essential services. For the essential service, we can use part of it, for example, the counseling for the contraceptive, and if they need something on site like the insertion of the ICD or the injection of the, for example, the implant, then this will be an essential service and they can take an appointment for that. The medical eligibility criteria, we should always remember this. They grade it from usually from 1 to 4. 1, there is no restriction, you can use it. 2, advantage outweigh the risk. 3, the risk outweigh the advantage, so you don't use it unless really there is no other way. Is unacceptable. Well, I just remind you that immediate postpartum insertion is easy and not difficult. You put it at the fundus and you make sure that you keep it at the fundus and you cut the thread around 6 centimeters. Maybe you put it into the beginning of the endocervical canal. Again, placement should be within 10 minutes of the delivery of the placenta. Can be done following normal vaginal delivery or cesarean section. We know that the expiry is 20%, but remember that many, actually more than 40% will start sexual activity before actually the starting using any contraception, despite they want to use this. So the expulsion rate is high, yes, 20%, but if you look overall, it is actually better than not doing it. So the continuation, some of the patients will have already LARC, Implanon, for example. So it's supposed to be 3 years. The evidence now shows that we can tell them, don't worry, wait for up to 5 years. The hormone contraceptive device, like the Mirena, for example, the 52 levonorgestrel, it's supposed to be 5 years, but actually there is evidence now that it can stay and can be effective till 7 years. So we can do this by teleconference, by anyway. The copper ICD, it can stay up to 12 years. The only thing that if you wait for a long time, the copper may disintegrate, but it does not reduce the efficacy or the effectiveness of the ICD. Unlike, for example, the Nova T, that there is silver in the core of the wire, this actually reduces the disintegration of this. Again, all LARC methods after the age of 45 can be left till the age of 55. So we can reduce actually the patient coming on site to the and give them consultation easy. The pills, we can give actually continuation for 12 months instead of repeating this. And they can measure the blood pressure by different means, either at home or in the pharmacy or other places. And the DMPA, the long-acting progesterone, the 3-monthly, can shift to the self-injection subcutaneous 12-monthly. We need to make sure that give a bridging method if needed. But if the patient wants to stop the method to get pregnant, I guess is an essential service and should not be postponed and should be given a time to come to the clinic. There are certain actually precautions for the patient to come to the hospital. Again, all should observe social distancing. By the examination time, if the symptoms, defer the appointment for 7 to 14 days, and as I mentioned, use the video online. The personal protection, important that we use this personal protection in addition to washing the hand after every patient and before every patient, also the distance as much as possible. We know that the family planning is a non-aerosol generating procedure, but again, we allow only the chaperone and exclude the partner. So this is very important. Again, the telemedicine and whether it is by phone, by video consultation, you can do the full range of methods of counseling. And again, you can give the temporary methods, the bridging methods. We know that the progesterone only pill is a good temporary bridging methods or the barrier methods. There might be actually in the coming period, as in some of the countries already been done, there is an online pharmacy, so they can you can go and collect the prescription and the medication or the contraceptive directly from the pharmacy. We can counsel on the extended use of the LARC methods and provide also emergency contraceptive part. The medical eligibility criteria, I'm just giving you a quick scenario. A 30-year-old female, history of migraine headache with light sensitivity. She does not experience visual warning signs or for a coming headache, and she's interested in starting contraception. So what are the methods that are safe? Would you give her combined hormonal methods or progesterone only or implant or intrauterine device? I'll give you a few seconds to think about this. Well, actually, all of the above, so long she does not have other risk factors for stroke. If so, progesterone only methods and IUDs are safe to be used. I just want to raise your awareness of some of the applications that are now where you can actually put the either the contraceptive or the medical condition, and then you can have the medical eligibility criteria where it is, for example, here, if there is an embolism, then the combined hormonal contraceptive should not be used at all, you know. And can give you also an explanation about why this is done. And there are different actually applications now, like the CDC, and also this from the Reproductive Health College as well. And this is again for the, if there is a migraine, if there is no migraine, so there is no aura, you can use all of them, but the combined hormonal contraceptive, really, there is some, they can actually, the less of them, you know, but again, can be used. So the telehealth actually would empower the social distancing, help reduce the COVID-19 exposure, preserve the staff availability and the personal protective equipment to see the high priority patients. And you can use it for contraceptive counseling, method initiation, continuation, switching. But again, we have to be aware about the how to do this in a commercial way or for the insurance to pay for it. So this needs the special system to be put, and we need the privacy regulation also for this. And they will end with an electronic prescription, so you can go directly to the pharmacy to pick it up. For the capacity of the family planning units and staff members, we know it is an issue during the pandemic, and we have to address this and also address the shortage of the personal protective equipment. And this should be actually daily reviewed, and we have to maximize the use of telehealth. And I think this is going to be the future, and we need to develop new counseling and clinical skills, and probably there will be certification for the medical, for the health providers for this. So my key message is COVID-19 is expected to disrupt the planning health service, especially if the second of COVID-19. And we need to ensure the supply of modern contraception and social distancing should be respected. We need to put consideration for the LARC, the implant, the postpartum IUDs, or the contraceptive hormones to be and method should be promoted and supplied proactively, whether it is pills, self-injectables, and see. I think medicine is coming as to improve information, contraception, probably to certification and accreditation for in contraception, and health workers really provided protection, and the government, it is an essential service. Thank you very much for your attention.
Thank you very much, Professor Nouri. This is an excellent presentation. And if I have a comment, what do you think the extension of the precautions that we should take, for example, here in Egypt as regards COVID-19? I mean, many people now feel that the era of COVID-19 has already been gone or done in a way. They are not taking any precautions. Even doctors are doing that here in Egypt. So in your opinion, how long should we consider taking these precautions as regards distancing, as regards telemedicine? I mean, till when? When can we say that we will return back to normal in managing our patients in clinics and hospitals?
Thank you, Professor Mumtaz, for this excellent question. We know that the people really now feels very relaxed, and I'm currently in the north coast of Egypt, and you can see people really too much relaxed for that. But if you look at other countries, that when the levels start to go down, as I mentioned, they started to have a second wave of COVID-19. And they started again to lock down and ask people to do quarantine again. So I think that we are following a pandemic and international trend. So one really should be careful about this, and we have to keep this very, very important, and again, we have to start to use the in our think that this would be the future.
Professor Salem, please.
Yes, there is a question for you, Dr. Amr. I think you've answered it already. Should a patient with COVID-19 stop oral contraceptives because of the increased risk of thrombosis?
Well, I think the patient with COVID-19, we know that the thrombosis is one of the causes of morbidity and mortality. And I think if you add the combined hormonal contraceptive in particular, this actually increases the risk of thrombosis. So I think that, yes, they should stop this. And again, I think that at this time, having the COVID-19, they should be isolated from their partner at that time, so not to infect them. So I would recommend them to not use, to abstain from intercourse completely.
Okay, thank you very much. Professor Mumtaz, you're muted. You are muted.
I was just making sure to prepare for his presentation. Thank you very much, Professor Nouri. I'm sure there will be other questions at the end. I'd like to welcome Professor Ayman Abu Noor. He is with us now. He is, of course, the professor and former chair of the Department of OBGYN at Ain Shams University. The presentation he's going to give us is fourth generation contraceptive pills. Could we dream of any better? Professor Abu Noor, can you share the screen with us, please?
Yeah, I can. Yep. You have to just unshare. Stop sharing. Yep.
Can you stop sharing your screen? Thank you.
That's good. Okay. It should be there right now.
It is there now.
Okay. Now, thank you very much.
Can you make it full screen?
Yes. It is full screen. It is full screen.
Now it is.
Yeah. Okay. Now, thank you very much for all the sponsors and for our wonderful professors and colleagues. Now, we're going to talk about ethanol estradiol with gynecologist as a fourth generation progestins. Okay, now why do we need more contraceptive pills? We have reached a great degree of safety in contraceptive pills. So to develop something else, that means that we're getting more benefits. So we have to get more benefits to accept using something new in a normal patient. Now, the fourth generation progestins, we have Gynecologist, drospirenone, normegestrol. In Egypt, we only have Gynecologist and drospirenone, and I'll be talking mainly about Gynecologist in comparison to the other. We used to have second generation progestins in Egypt, which was Nordet and Microvlar, and they were so androgenic that the chicken farmers used to take them and feed them to the chickens to make the chickens bigger. Then in the 80s and 90s, we got the third generation progestins, which were non-androgenic. So we have the second generation progestins, which are androgenic. Then we pass to the third generation, which are non-androgenic. And now we have the fourth generation, which are essentially anti-androgenic. So we are passing in phases from androgenic to non-androgenic to anti-androgenic. All right. Now, what's the difference between Gynecologist and other progestins? It's an agonist of the progesterone receptor, but it has a very special character. It is very weak in vitro and extremely strong in vivo. What does this mean? This means when it enters the endometrial cell, it works very well because it's converted into a stronger compound. While it's in the circulation, on the rest of the body, it doesn't work that well. So it works more or less like a magic bullet. I want it to act on the endometrium and it works very well. I don't want it to act on the rest of the body, so it doesn't work that well. So we can have nothing better than that. Where I want it to work, it works. Where I don't want it to work, it does not work. Furthermore, the metabolites may be active. This means that even if we forget a pill, the failure rate will be very low because I still have metabolic activity from the metabolites. This is something of value because if the patient forgets, we can still have a low failure rate. So what it does in the endometrium, it causes atrophy of the endometrium. It is anti-proliferative, anti-androgenic, and it even reduces endogenous production of estradiol. And we all know that if we are going to produce endometrial atrophy, it's very hard to become pregnant, even if we have breakthrough ovulation, which doesn't really happen. So it has an exceptionally high efficacy. Furthermore, it can prevent and even treat endometriosis. We all know that endometriosis, we have first-line therapy, then second-line therapy, then third-line therapy. We usually revert to the third-line therapy, which are aromatase inhibitors, because they block endogenous production of estradiol by the endometrial implants. So what I'm going to do is I'm going to give a drug which blocks the endometrium and stops it from producing its own estrogen. So I'm actually, even though I'm a first-line therapy, I am as effective as the third-line therapy. So most of the patients with endometriosis. Furthermore, if a patient is young and I really want to give her contraception, but I don't want to have a problem of endometriosis later on, so I'm actually protecting her from endometriosis. So I'm preserving her fertility. So they have exceptional high efficacy, prevents and treats endometriosis, which maintains her fertility and can even prevent endometrial hyperplasia and cancer. What happens is some of the patients come, I don't want to take pills, they cause cancer. We tell them, well, they don't cause cancer of the breast or the relationship is not well known, but we definitely prevent cancer of the uterus, cancer of the ovary, and cancer of the colon. So this is another point in favor of these contraceptives. Okay, so why not use them alone? We can use them alone if they're that good. No, it's better in contraceptive pills to give them with ethinyl estradiol or estradiol valerate. Why? Because the cycle control is better, and we all love estrogen. Estrogen is a mood hormone. Patients with estrogen like it. Patients with lack of estrogen hate it. Patients after delivery, after menopause, they hate it. During the cycles, they hate it. So giving it, although giving it alone can be contraceptive, We prefer to give it with ethanol estradiol or estradiol valerate to give excellent cycle control, and we have the beneficial effects of the estrogen. All right? Because it controls the endometrium extremely well, the possibility of breakthrough bleeding or spotting is lower. And these are one of the main factors which cause the patient to stop or cease use of contraceptives. On the androgen receptors, because they are fourth generation, they are anti-androgen. And they have 30 to 40% the effect of CPA, cyproterone acetate. We all know the prolonged use of the CPA is not that good unless you do periodic liver testing. So this can be even better than using combined pills with CPA, all right? It can improve acne and hirsutism. Because I'm a fourth generation, I am anti-androgenic, so it does have. And the metabolites themselves have high affinity for the androgen receptor, so they have a prolonged action. Does it affect the estrogen receptor? It does not. It does prevent local production and estrogen effect on the uterus, but does not block it on the rest of the body. So the estrogen is good. We don't have the mood effects, the effects of lack of estrogen, they're not there. That it's almost a magic bullet. I'm leaving estrogen to do what it does good, and leaving progesterone to do what it does well, and I'm not letting progesterone affect the rest of the body. On sex hormone binding globulin, it binds mainly to albumin. It does not bind to sex hormone binding globulin. Now, the failure to bind to sex hormone binding globulin is good because it does not displace androgens so that they can cause more androgenic action. So we have another advantage for these. It has no effect on corticosteroid receptors, should not cause salt on water retention. Non-hormonal benefits are like the rest of the combined pills. Menstrual bleeding disorders, and it may be therapeutic. Professor Ali Koba said, in the FIGO, we can use Mirena or LNG-IUS for bleeding. If we're not going to use that, the FIGO says the best is a Dionogest-containing pill. They use Clyra or Valetta. Here in Egypt, it will be called Marta Viva. So we use it a lot in menstrual bleeding disorders. We get a huge number of people, all right, with bleeding disorders or heavy menses. These are good for them if they do not want Mirena. It's good for dysmenorrhea. We use it in teenagers and patients going for exams. It's good for premenstrual syndrome and dysphoric disorders, even though it's not first-line therapy for dysphoric disorders. We usually give cyclic SSRIs or SNRIs, but we can give it as second-line therapy. Used for androgens. Here in Egypt, we are part of the Mediterranean region. Our mean Ferryman-Galloway score is around 11 or 12. So we have a high risk of hirsutism, high risk of acne, so we can use it. And this is one of the benefits for these. It can reduce ovarian cysts, can reduce pelvic inflammatory disease because it causes thick cervical mucus, and the endometrium is very atrophic. It's not conducive to the organisms to live on it. Estrogen improves arthritis, preserves bone density, which is very good because some people like injectable contraception. We all know that use of depomedroxyprogesterone acetate can adversely affect bone density in some studies. So if you really want to preserve bone density, that would be better. Endometriosis, adenomyosis, it might even have a beneficial effect on uterine myomas. We all know in our country, we have a huge number of patients with myomas. It might affect benign breast disease, and it reduces ovarian cancer, endometrial cancer, and colon cancer. So we have a host of a lot of benefits. Why? Why is this important? If I'm going to stop giving second and third generation, and I'm going to give fourth generation, I have to have additional benefits. The Pearl index is very low. Why? Because the compound has a longer duration of action, and the metabolites are very active, and we are very active against the endometrium. We can prevent and treat acne, but I want to say something. In cases of acne and hirsutism, it's usually not enough alone. You should give something else with it. Produces excellent cycle control, very good for the patients. Here in Egypt, patients hate it when they have irregular cycles, reduces heavy menstrual bleeding, and we can also use it endless. It was introduced to the market for endometriosis, but it's a better use for contraception. Side effects are very mild: headache, breast tension, temporary nausea and vomiting. These usually subside in a few months. Let's look at a few cases, 2 or 3 cases. 23-year-old wants contraception. She's going to be married after 2 months. What is the best option? All right. She's scared. The main scare or the main concern is that when she stops the pills, she might not become pregnant. So we counsel her that this is actually protective. You can use this and it will block any endometriosis. It will block PID, might block fibroids. So this is safe for you. It is extremely effective. If you have studying or exam, or whatever work you have, then you can use this and it will be protective. We are using it here for the benefit of the patient, not just because she wants contraception, but because we want to protect her future fertility. Let's suppose a soon-to-be husband calls to tell you that his fiancée has horrible acne. Called me out of the blue. She looks fine when she's on isotretinoin, but when she stops, woo, she looks very bad. And he wants to marry her. What's the management of the case? All right, so she's going to have to take isotretinoin. We cannot take isotretinoin when we are married unless we have good contraception. So if we're going to use good contraception, it's better to use a contraceptive which has a beneficial effect on acne. All right, so we will add these Dynogest containing pills. All right, and we might even add an anti-androgen. All right, I prefer giving finasteride, which is Proscar 5 milligrams per day. It is not a steroid. I know some people like CPA, but CPA is a steroid and you can only give it for 10 days a month. All right. Some people like spironolactone, can cause metabolic potassium and stuff abnormalities. Finasteride has almost no side effects and the patients love it. They really love it. Why not we just give finasteride? We can't do that. Why? First of all, the patient might become pregnant and we cannot allow that. Second, is that we are giving Dynogest with estrogen. The estrogen will increase sex hormone binding globulin and further bind what little free androgen is left. All right. So we have a double effect here. We are doing 2 things at the same time. Let's look at this patient, 27-year-old with hirsutism. All right. She's doing repeated laser sessions, but she now notices fall of hair. So she has some female pattern baldness. Okay. She's married. Should we give anti-androgen management and should we give an adjuvant? Yeah. COC with Dynogest is good because she's married. So we will give the anti-androgen, maybe finasteride is fine. And we have to block the pregnancy. It's better to block the pregnancy with something which has an anti-androgenic action and which improves the sex hormone binding globulin. Okay? So it's the same thing. So we can use it for straight on contraception, contraception which we must preserve fertility, contraception in patients which have acne, contraception in patients who have hair loss or have acne. 21-year-old virgin has increasing pain with each cycle. It's becoming unbearable. Ultrasound, there's no apparent ovarian pathology or obstructive genitouria. You give her a trial of progesterone, the pain improves, but she gets depressed. This is probably a therapeutic test for endometriosis, but the patient is now not tolerating the progesterone alone. So it's better for us to give her Dynogest or better COCs with Dynogest because we don't want lack of estrogen, but we really want to block the effect on the endometrium. 34-year-old with heavy menstrual bleeding for 2 years. Endometrial thickness is normal. You insert a Mirena IUD, but the recurrent spotting is driving her mad. This is AUBE, abnormal uterine bleeding due to endometrial pathology. AUBE is usually treated with COX inhibitors, but sometimes they don't work alone. So in this case, it's better to give something which causes the endometrium to be very thin. So here we give a COC, which reduces menstrual bleeding, almost the only one recommended for reduced menstrual bleeding significantly is the Dynogest container. 15-year-old has been sent to you by the hematologist. I remember this patient very well. She has ITP and the platelets are 16,000. She's on corticosteroids, azathioprine, and he's even taking biological treatment. Hemoglobin is 7.2. She needs menstrual suppression. She is 15. How will we do menstrual suppression? We can give her long-acting progesterone, medroxyprogesterone, but she's too young for that. We might affect peak bone mass. So it's better continuous COCs with Dynogest. We don't even have to stop for the 7 days. It works fine. Patients come back. They are very good. 22-year-old university patient, a student has menstrual migraines. She can't study because the exams are coming and she has menstrual migraines. If you are sure that it's menstrual migraines, we can use continuous combined pills. We can use continuous combined pills. But menstrual migraines are migraines only during the menses. So what we want to understand, that we have 3 types of decision-making in gynecology obstetrics. We have an informed choice. We will tell the patient everything and she chooses. We have directed counseling on the right. I prefer the patient take something, and we have shared decision-making. I would always prefer something for the patient. The patient always prefers something. She might have read something. If you are good in counseling and tell her the benefits, the lack of risk, you allay her fears, then you can come to a shared decision-making which causes overlap of both. And this, you would have the best of both worlds. So the conclusions, Dynogest is unique, has anti-androgen action, which gives it many benefits. It's superior to other progestins for excellent endometrial suppression, which gives very good cycle control and prevents endometrial diseases. Has no bothersome anti-estrogen, anti-corticoid properties because there's no systemic anti-estrogen effect. Side effects are few and well tolerated, and it's beneficial in other conditions as prophylaxis and as acute. Thank you very much.
Excellent presentation. I have a question, and I think there are many other questions in the list. First, what are the contraindications for Dynogest in particular? Are there any contraindications for Dynogest as the progestogen in the combined oral contraceptive pills compared to other progestogens or not?
No, we have to go by the WHO eligibility criteria, and they do not separate types of pills or types of combined pills. So even if we think it's safer for certain patients, the contraindications will remain as the general contraindications.
Okay. The second question, I think it's also in the Q&A, is how long can we use combined oral contraceptives? Till what age is it safe? And of course, can we continue as a treatment for menopausal symptoms or not?
Yeah, that's a good question. Well, what happens is that we can continue till the age of 50, provided there are no contraindications. Now, can we continue them as a hormone replacement? What happens is that in Egypt, sometimes we have a lack of hormone replacement options. So if we are going to continue with hormone replacement, I would give a 20 microgram ethinyl estradiol pill, which is equivalent to 2 milligrams of estradiol valerate. All right. So we would probably go for the lower dose, as Yaz maybe, for the hormonal replacement therapy if I really needed it. All right. So that would be better to keep the estrogen a little bit lower for hormone replacement. But generally, combined pills, you can go until the age of 50.
Professor Salam?
Yes, I think we have a few questions also for all the distinguished speakers. Professor Ayman Abu Noor, Mardaviva or Dianet for hirsutism?
Yes. For hirsutism, if you wanted to work, you would give Mardaviva, which is Dynogest with ethinyl estradiol, and add Proscar, add finasteride, 5 milligrams a day, continuous for 6 months. We do not have the 1 milligram preparation in Egypt, and the tablets are not scored, so we cannot give 2.5 milligrams. The 5 milligrams work wonders. They are not steroids. Side effects are almost non-existent. And they even work better than the CPA and better than the spironolactone. It really works very well. The patients love it. And I really want people to try. I used to give, I stopped giving spironolactone maybe 20 years ago. I used to give CPA, but I've stopped giving high doses of CPA maybe 3 or 4 years ago. All right? Because CPA, you have to do liver function tests repeatedly. Sometimes CPA is a very long-acting hormone, very long-acting. Half-life 2 to 4 days. So sometimes you don't get withdrawal bleeding. The patient gets scared that she might be pregnant. She comes back a lot. We have to give it only 10 days. So CPA has some limitations when we use CPA.
Yes, there are a few questions to Dr. Ali. For example, psychological side effects with Mirena. Are they, what should we do with them? Is it a good idea to have Mirena in patients with postpartum blues?
Well, if you look at the percentage of side effects, most of the progestogenic side effects can happen with Mirena. They will happen probably in the first 6 months where the blood levels are a bit higher. But if you want a ballpark figure to talk to the patient about 2% of patients who use Mirena may get psychological symptoms. You can definitely use it for women who have history of you know, psychiatric depression or something to that effect, because the effect is minimal. It may be worthwhile actually in these situations to try to use natural estrogen. We've used, a long time ago, we've used natural estrogen definitely with women who get premenstrual syndrome and are using a progestin-only method. So that is one aspect. And obviously, if a woman is using, let's say, an SSRI, there is no contraindication in using Mirena at the same time or adding estrogen.
Yes, sir. Mirena with migraine.
Again, it's because it's an estrogen-free method. It is fine with women who have migraine. It actually is also safe, and it was in one of my slides, which I didn't spend too much on. It's also okay with patients who have migraine with aura, with focal symptoms. It's not contraindicated. The pill is contraindicated. Estrogen methods are contraindicated, but not progestogen-only methods.
Yes, there is a question for Professor Amr Nouri. If a patient gets COVID when in her first trimester, should she go for termination of pregnancy? You are muted.
Thank you, Professor Salam. This is a very important question. Again, there are, as I mentioned, that 30% will be asymptomatic, 50% will have mild flu-like symptoms, and you have 10 to 15% will have severe symptoms. I think if the patient is not having severe symptoms, I mean persistent fever, then there is no risk and there is no evidence of increased risk of miscarriage or teratogenicity. However, if there or severe acute respiratory syndrome, again, this would be a very high risk, and maybe in this case, one may think about the termination in these cases. But the mild cases of the COVID is not really up till now proven to show any risk for the pregnancy. We know that there is vertical transmission, and also there might be transplacenta, but this is later on in the third trimester and at the time of delivery.
Yeah, another question from Professor Abu Bakr. Professor Abu Bakr Nashar, everybody knows him, and others asking about the resumption of oral contraceptives after COVID-19, particularly that thrombosis can happen years later, many months later. So when should people resume oral contraceptives?
Yeah, this is a very important question. Again, the majority of the patient will actually within 2 weeks will recover. Some people may take up to 6 weeks to 3 months. So really depending on every case, if they become immune and they are really fit and well, they can resume, go back to the hormonal contraceptives. But again, every case should be taken in its way, yeah.
Yeah, okay. And the management of when they stop oral contraceptive, they will have bleeding. So what do they do with this bleeding? I guess there is no difference between those who have COVID, but it's up to you to answer.
Well, I think we have to, if it is heavy bleeding, then we can use maybe the other medication that stop. We have the ethansylate, for example. Maybe people will be a little bit scared because of the risk of thrombosis of the tranexamic acid. But again, you have to use really what you have according to that. But you will not going to give a combined contraceptive pill in a patient with COVID-19.
Yes.
Thrombosis of these patients.
Yes, there are a few questions again for Dr. Ali, and then some questions for the whole panel. For Dr. Ali, can we keep Implanon for more than 5 years? And can we use it for increased blood pressure and hyperthyroidism? You're muted, Dr. Ali.
So we didn't discuss Implanon, but it's one of the long-acting reversible contraceptives. So it's a very, very effective contraceptive, for sure. Again, it's a progesterone-only method, and therefore the contraindications that apply to estrogen-containing contraceptives doesn't apply to it. So yes, you can use it. Can you use it for 5 years? Well, the license is for 3 years. We know that there is research to suggest that it works beyond that. The Faculty of Sexual and Reproductive Health in this country have said that it can be used up to 4 years. It hasn't actually said 5 years as such, and therefore I would be uncomfortable because of the possibility of litigation to actually say to someone they can keep it for longer than 4 years. I know that Amr said 5 years. I mean, that depends on the evidence we have, which means that if a person cannot access a replacement of their device, Amr mentioned that you can use a bridging method. And the bridging methods, obviously with the Implanon, with the subdermal implant, is the desogestrel progesterone-only pill. I don't know whether it's available in Egypt. It's called Sarazet in this country, in the UK. And that's a good bridging method until they can get to you as their gynecologist or to a clinic and have the Implanon replaced.
Yes, sir. What about a lady who has forgotten her IUD and went into menopause for a few years? What is the management? Should we leave it, or should we?
We recommend removal. This is something to be discussed with the patient. There have been rare situations where infections with an IUD that had stayed there for a long time works very much as a foreign body. As you know, there is also this association with actinomyces-like organisms, and these, in very rare cases, especially if the immune system becomes less competent, may cause a problem. And therefore, we normally would not keep an IUD and ignore it forever. We would recommend removal. The difficulty people have is they say, well, the woman is menopausal, the IUD will be stuck, it's a bit difficult to remove it. In most cases, it's actually fairly easy. But one of the things you can do is to actually give them estrogen for maybe 6 weeks, something to that effect. That will build a tiny bit of endometrium, will make it much easier to remove the device. So I would recommend removal, negotiate with the patient. Remember that you can keep an IUD until you assume that there is no chance of pregnancy. So in the UK, you can keep it up to the age of 54, even if the woman, for instance, has had amenorrhea, if she wants to be sure not to fall pregnant.
Yes, sir. Now, there are some questions for the whole panel. What is the best contraceptive for women with epilepsy? And for ischemic heart disease, and for obese women over 40?
So I would think, Professor Salam, that each of the speakers will answer the 3 questions so that we can have an opinion. What do you think?
Yes, sure.
Well, I can start because I was presenting something about medicated devices. I think a estrogen-free method is what you want. A long-acting method is what you want, and therefore you can pick any of these. And I think a Mirena or a copper IUD would probably be appropriate for these cases. I've forgotten what the cases were. Epilepsy.
Epilepsy.
Yeah. Epilepsy is not a big issue. Even if they use anti-epileptic medication that induce liver enzymes, both Mirena and the IUS is fine. There is a question mark about whether subdermal implants can be used with liver enzyme-inducing drugs because of efficacy. Obviously, people will worry about a patient having a fit during the procedure. The risk is fairly small, and if a patient has unstable epilepsy, it's worthwhile, especially in your situations where you would work in a hospital, is to actually fit it when in the hospital in case she needs some sort of a care if she has an epileptic fit. So that's for epilepsy. I'm going to leave it for the others to talk about.
Okay. So it's epilepsy and ischemic heart disease and obese patients over 40. Maybe Professor Bitzer, please.
Yeah. Can I add something to? I mean, there is this special case of catamenial epilepsy. You know, those women who have fits during menstruation. And there, I mean, the mostly recommended issue is actually EPO in continuous use to completely suppress these issues. So Mirena would be something in between, because usually, of course, copper IV would be a very good thing. But in those who are really related to menstruation, then I think you have to think of even of EPO.
Yes, sir. Professor Ayman Noor.
Yeah, I agree with the epilepsy that IUDs are very good. Maybe the Mirena would be better because her ability to make way with the bleeding, excessive bleeding, might be a little bit tricky. Regarding obese patients, also IUDs are better, definitely. Progesterone contraception, she can use it, but there is some concern if she's going to use progesterone-only pills about the efficacy. And in case of ischemic heart, progesterone-containing contraception should be fine. I don't see any problems with that. And of course, these are conditions which are hard. So the longer acting the contraception, the better.
Professor Hassan, can I just make two comments?
Please.
Because Ayman mentioned extended use of the oral contraceptive. In this country, in the UK, we are now recommending to patients that this is actually the way to use the combined contraceptive pill. That the normal thing is to use it in an extended way. You have no problem with someone missing one pill or whatever. You have no problem with the menstrual issues and problems. So that, I think, is one important thing. The other is obese women are at a higher risk of endometrial hyperplasia, and therefore a Mirena device, a medicated device, would probably hit two birds with one stone: the hyperplasia as well as their risk for cardiovascular disease, just as an option.
Professor Ali, I want to say something. Why was it 21 and 7? It was 21 and 7 because the people who made the pills wanted to present it to the Pope as something acceptable. Yeah. And he didn't even accept it. Yeah. So we were cumbersomely burdened by the 21/7 regimen just because we wanted to make something for the Pope, and he didn't want it.
Exactly. So, you know, it was a political rather than a scientific, physiological plot. Yeah.
Yes, sir. Okay. So the management of bleeding with IUDs. What's the best management of bleeding with IUDs?
Well, we did talk about it. So we did say that you can, in a way, the mechanism is not known, and therefore treatment buys time. I think if you're talking about a copper IUD, and if a person has used the IUD for a while, years that is, and then they start getting heavier periods, obviously do an ultrasound to make sure that they haven't developed some gynecological morbidity, fibroid, adenomyosis, whatever. It might be worthwhile actually changing the IUD, because sometimes when IUD is kept for a long time, you get calcium deposits on it, and that might impact on the bleeding. Change it to a hormone-releasing IUD, which is also another option. And I think if you're thinking of keeping the device, not disturbing it, but using some medication, you have a choice. You can, as I said previously, You can use tranexamic acid. Some people use mefenamic acid. And if they are allowed to use estrogen, these patients, you might just control the bleeding for a short while with an estrogen preparation, be it natural estrogen or a combined pill.
Yes.
Professor Salam.
Yes, please.
Professor Salam.
Yes.
I have a question for the panelists, actually. It's a very common question that have been asked by many doctors, actually. Usually, the problem in Egypt is that to postpone the first pregnancy. And I want most of the attendees to hear from the panelists, what would you do for a woman who comes to you saying, I'm going to get married after 2 months, and I want to postpone the first pregnancy, say for 6 months, 1 year, 2 years. What advice should you tell her? Because I've seen many patients who come, who have been visiting other doctors, and they tell them, obstetricians and gynecologists in Egypt and in other countries, you should not use any contraception to postpone the first pregnancy. It's not safe. Get pregnant, deliver, and then use contraception. So I want them to hear from our panelists, what would you do for a patient who comes to you, young, healthy, and she wants to postpone the first pregnancy? What advice would you tell her?
So we need to broadcast this on, I don't know what is the popular television channel in Egypt if we want to talk to the women. I mean, contraception is safe. It's safe from a fertility point of view. It's safe for nulliparous women as well as parous women. You can talk to her about the NICE guideline, the National Institute for Clinical Excellence, which essentially says there is no difference. So I would dismiss, I think that is the wrong advice, as a matter of fact. And I think in our countries where we really are aiming for the sustainable development goals, the status of women, their education, their status in society, actually burdening them with a pregnancy very soon after they get married is sometimes detrimental to their aspirations. Obviously, it's very individual. So it's not about us forcing an opinion. It's about allowing the couple, the woman, to make a decision. If they feel they don't want to embark on a pregnancy that early, if they feel getting married is for fun rather than for children, I mean, we have to accept that that is now an option. Then I think they can use any of the various choices of contraception that is available. But we need to be some sort of a TV.
Sorry, if I may say,
Professor Blitzer?
I'm even more critical. I think it's unethical to tell a woman that she should get pregnant because if she postpones it, she will have problems. This is just wrong information, and it is and in this context, this is bad medicine. So I'm sorry. I hope I will still be able to come back to Egypt, and they won't let me.
No. Actually, I want everybody to hear that, because this is the sound medical advice. But sometimes people are afraid because of social words or coming from their families and so on. So sometimes some doctors would be afraid to say something opposite to the tradition and so on. So I want everybody to hear that it is wrong to tell a woman that is going to get married, that is, you should get pregnant in the first place and then think about contraception. So I totally agree with you, Professor Blitzer.
Okay, could I interject? Well, what
Professor
happens is,
please.
yeah, if the patient is in the late 30s, then I would probably have to tell her that the ovarian reserve will decline, okay? Because once she gets to 40s or something like that, it might be too late. So we have to individualize the question. Let's say a patient who is young, I would actually ask her, are you sure, or might you change your mind? If she says, well, I don't know, this says she's gonna change her mind, all right? So we have to give her a method which provides autonomy, so she can change it easily, all right? We tell her, what do you want? You want something very effective? We can go for the pills. Or you want something less effective, intercourse related? I never propose intercourse-related methods because it puts pressure on the two young couple. A patient who is just married in her honeymoon should not be doing safe period. A patient who's on her honeymoon and her husband is going to have intercourse for the first time with her should not be with a condom, okay? A patient should not have coitus interruptus. Temperature is very fickle, especially here in Egypt. A lot of patients wake up at 2 in the afternoon. Not everybody wakes up in the morning. So what happens is that if the patient is really motivated and she's very interested on these non-medical methods, then we'll help her out. If she wants a medical method, a pills is very good, and we tell her that these will protect her fertility, so she doesn't have to worry. If the patient absolutely needs not to have children, you have a patient who works in the airline industry. If she becomes pregnant within 3 years, she's going to be fired. Then we have to go something more effective, and we even propose Mirena in these cases. So each patient is his own animal. Yeah, not all patients are the same. That's what I think. But telling the patient she must become pregnant is an absolute no-no. All right. Telling the patient she must use a certain method is an absolute no-no.
Thank you very much, Professor Ayman. I think we have plenty of questions. I don't think we'll be able to answer them there. Also, the final question would be for you. Can we use Dynogest for endometriosis treatment? I guess you've said this. Can you use it continuously or in an interrupted way?
Yeah, I know the question. Yeah, what happens is Dynogest was introduced by Bayer in the form of Visan, costs 300 pounds.
Fourth generation contraception, yeah.
Yeah, if we are going to use Marta Viva, it will cost 1/4 of the price, or
Yes.
1/3. And it will produce more or less the same result.
Yeah.
So from a cost-wise benefit, it's better to use the Marta Viva. Furthermore, contraceptive pills are much better for the mood than progesterone alone. So it's much better for her, and she can use it extended use, 3 months, 6 months, and she will be happy with the estrogen. Because a lot of patients on Dynogest alone complain, no, it's not that good. I'm not very happy. So that's what we propose. And if Professor Johans has another opinion, I think he knows a lot about this subject too.
Would you like to add something, Professor Bitzer? You're muted, you are muted, you are muted. We can't hear you.
I agree with you. I mean, regarding treatment of endometriosis, of course, you would like to avoid estrogen. And if you want to really have a very focused treatment of endometriosis, it's probably really better to just give Dynogest alone. I agree that, and it was mentioned several times before, that some women are sensitive to progestins regarding their mood changes, which we know also from the natural history of PMS and PMDD. So in these patients, yeah, you may be better off with a combined Dynogest preparation, and thus maybe have two things at the same time: suppress endometriosis because you don't heal it, and or suppress the symptoms of endometriosis, to put it in a correct way, and at the same time have good tolerability.
Thank you very much, Professor Bitzer. As I said, we have plenty of questions, but we will ask maybe the speaker, is they are kind enough to answer them. We will send them back by mail. And with this, I hand my microphone and my video to Professor Momtaz to thank the speakers again and finish off the webinar.
First, I'd like to thank you, Professor Salem, for the excellent preparation and moderation for this webinar. You've been worried about it for the last couple of days. We've been doing a lot of rehearsals and preparations. I'd like to thank very much the Techno Company for organizing this meeting. I'd like to also thank the speakers. I think it was an excellent meeting with about 600 attendees from all over the world. I think it was an excellent meeting. Thank you very much all, and I hope we can have another meeting soon with this wonderful group of speakers. Thank you very much. I'd like to.
Hopefully in Egypt in person. Hopefully. Once the
Sure. Professor Blitzer wants to come to Cairo, and he's most welcome, of course.
Of course.
Yeah, he's been here several times. He's going to come again and again.
Yes.
He's
Cool.
We really enjoy him here.
Thank you. I love
you very much. And thank you for all the audience, and thank you for Techno and for the organizers for the meeting. And thank you very much. As we say in French, à la prochaine, Professor Bitz. À la prochaine.
Thank you all. Bye-bye.
Bye-bye. Thank you, Ali. Thank you, Ayman. Thank you, Mumtaz. Thank you,
Mumtaz. Thank you, Ayman. Thank you very much, Dr. Ali, Dr. Ayman, and Booster Bees, and Dr. Amr. Enjoy your time. And thank you very much for your information about COVID. And Dr. Ayman, really, it was a great presentation.
Thank you.
I think Techno will be pleased. Bye-bye. Bye-bye. Bye-bye, everybody. Bye-bye. Bye-bye.